Welcome back to the Vitrolife Group Academy Studio. It is my pleasure to introduce you my colleague and friend, Dr. Tiffany Stankiewicz, who's going to talk about the EMA analysis. So Tiffany, whenever you want.
All right, perfect. Thank you, Nasser. So thank you for joining us today. We're talking about advancing the analysis of the endometrial microbiome. So when we look at the periconceptional space, we know that the embryo encounters the endometrium, and the first kind of phase is the endometrial microbiome. So what kind of bacteria are in the endometrium that can either affect or improve implantation? So I want to start with an introduction of the microbiome in general, looking at the Human Microbiome Project that was launched in 2008. It's a strategy to understand the microbial components of the human genetic and metabolic landscape and how they contribute to normal physiology and predisposition of disease. So some fun facts about the microbiome in general. Humans have 10 times more bacteria than cells living in our bodies, particularly in the skin and digestive tract. So in a person that weighs 70 kilograms, approximately 1 kilogram is going to be due to bacteria. And between 20 and 60% of these bacteria, depending on their location, are not cultivable under standard laboratory conditions. Now, approximately 9% of the bacteria within our body are located within the urogenital tract. In the vagina, it is normally defined by the presence of bacterial species of Lactobacillus genus that are commonly associated with healthy genitourinary status. The vaginal microbiota typically changes throughout the menstrual cycle, and these changes can lead to several pathologies that could have implications for both reproductive and obstetric complications. So when we look at the microbiome through the reproductive tract, what we typically find is a very high biomass within the vagina, but very little diversity. And as we move up to the reproductive tract going towards the ovaries, we see the biomass decrease, but the diversity increase. Now, today we're focusing on the uterine microbiome, specifically in the endometrium. And recent research has identified the existence of an endometrial microbiome and has demonstrated that this dysbiosis of the uterine cavity is associated with poor reproductive outcomes in assisted reproduction treatment patients. So, for instance, in this early study by Moreno in 2016, what we did is that we looked at different microbiomes, so the endometrial fluid and vaginal aspirates from the same patient. And although we found that a majority of the bacteria belonged to Lactobacillus, we did see differences within these microbiomes, showing that the endometrium did indeed have its own personalized microbiome different from that found in the vagina. Now, when we actually looked at the different bacterial profiles, we associated to different clinical outcomes. We saw that patients with a high level of Lactobacillus and very little pathogens had higher likelihood of live birth versus those patients with miscarriage or not pregnant, where we see a high percentage of pathogenic bacteria. Now, we looked at the outcomes of 35 patients, and what we found was that those patients with a high level of Lactobacillus versus patients with high levels of pathogenic bacteria had significantly higher pregnancy rate per transfer, implantation rate per transfer, ongoing pregnancy rate per transfer, and live birth per transfer. We also saw a difference in miscarriage rates between both groups. However, this was not statistically significant, but in the case of Lactobacillus dominated, we had 16.7% miscarriage rate versus 60% in the non-Lactobacillus dominated. So not only does it appear that this microbiome and optimal microbiome is important for implantation, but also the maintenance of pregnancy. Now, I do want to talk about therapies for microbiome, and this was a recent paper from the group in Japan ran by Dr. Awami. And in this particular study, they wanted to determine if analysis of the endometrial microbiome and its recommended treatments have positive impacts on pregnancy rates in patients with recurrent implantation failure. In this study, it was a prospective cohort study in a single center in which they utilized the EMA test by iGenomics. A total of 195 women with recurrent implantation failure were enrolled, and the primary outcome measured was cumulative clinical pregnancy rate after 2 additional FETs. And what was found that 1 in 4 patients needed antibiotic therapy because pathogens were found in their endometrial microbiome. Now, what is an advantage of molecular technology versus, say, histology or hysteroscopy is that we get objective information about the bacteria within the endometrium itself. So that means we're able to give targeted antibiotic treatment for those pathogens detected. So in this particular study, 90% of the antibiotics administered were not broad spectrum, but were instead targeted to the specific pathogens. Now, when we look at the study group that utilized the EMA test and followed the recommendation provided, we had significantly higher HCG positive rate, clinical pregnancy rate, ongoing pregnancy rate, and delivery rate versus those patients that did not undergo any testing at all. Now, to quickly introduce you to the EMA test, EMA stands for endometrial microbiome metagenomic analysis, is a molecular assay used to determine whether the uterine microbial environment is optimal for endometrial health. So this molecular method is based on detecting and measuring the amount of DNA present in the endometrial samples. Here, we look at Lactobacillus species, which is the good bacteria. So I always think of these as a safety net, keeping the pathogens at bay. We look at reproductive tract pathogens, and we also look at those bacteria that are related to chronic endometritis. So that's included in our ALICE test, which is analysis of infectious chronic endometritis. So with EMA, we get a full microbial view of endometrial health. So looking at the process here, if we have, let's say, normal results, the recommendation is to transfer within this next month. We know an optimal microbiome is present, and since the microbiome can be transient in nature, especially affected by external things such as antibiotic use, sexual intercourse, hygiene, clothing, etc., we want to ensure this optimal situation and transfer as soon as possible. If there is a dysbiosis where we see low levels of lactobacillus but no pathogens, then we recommend probiotics and then proceeding with transfer. And then in any case where we see pathogenic bacteria outside of reference range, we recommend targeted antibiotics followed by probiotic and a test of cure biopsy to ensure optimal microbiome. Looking at our global data, you can see that this agrees with the study from Dr. Iwami, in which approximately 1 out of 4 patients will need antibiotics because a pathogen has been detected outside of reference range. And with that said, about 70% of patients will need probiotics, again, to provide that safety net with lactobacillus to keep pathogens at bay. So now I want to take the opportunity to introduce you to upgraded EMA and ALICE. This test was launched here in the US and worldwide in May of this year. And this test is based upon our knowledge with the endometrial microbiome, with over 5 years of running analysis with next generation sequencing and over 70,000 samples worldwide. We can now provide a more complete view of endometrial health because we know which are the most prominent bacteria found in the endometrium, allowing us to create an endometrial specific panel. So this is very important. So based on this data, this exceedingly precise and complete endometrial panel contains 97.8% of the bacterial pathogens detected with NGS. And what is relevant about this is that we report at the species level, not the genus level. And why is this important? Well, we could have 2 different bacterial species, a part of the same genus, but maybe one is more effective with one antibiotic than the other one's affected by another antibiotic. So this will allow us to give an even more targeted approach to creating an optimal endometrial microbiome. So one thing I do want to point out on our reports, which is specific to iGenomics, and this is based upon our scientific experience with the endometrial microbiome, is that we simply do not just indicate whether a bacteria is detected or not detected, but we do supply a reference range and give a corresponding value for that endometrial biopsy sample. Why is this important? Well, Again, these are scientifically established values, reference range based on endometrial microbiomes from women undergoing IVF with subsequent live birth. So we correlated those women's microbiome who had subsequent live birth, and we were able to calculate the reference range. And what this does is that it prevents the overuse of antibiotics when they're not necessary. So if you joined my talk yesterday with Dr. Amy and Dr. Rogers, we discussed that by 2050, it's estimated that there'll be more deaths per year from antibiotic resistance than cancer. So we all need to do our part, make sure that we're using antibiotics responsibly, and in that sense, using targeted approach versus broad spectrum. Another new aspect of the upgraded EMA for the US is that starting next month, you will get a direct recommendation for antibiotic and probiotic therapy. So previously, we just provided the bacterial profile and then different antibiotics that were effective for different bacteria. Now, you'll actually see a direct recommendation. So example, in this case, based upon the patient's bacterial profile, the recommendation would be amoxicillin, 500 milligrams every 8 hours for 7 days orally, followed by vaginal probiotics made of lactobacillus. So we're taking some of the guesswork out of this and giving more a targeted and personalized approach. So the conclusions here is that the microbiome is an emerging area of study in human health and disease. So not only in reproduction, but we know its significance outside of that too. The vaginal and endometrial microbiome are different, and we need to use proper panels to study each. We cannot use a vaginal panel to study endometrial microbiome. The presence of pathogens in the endometrium is associated with poor reproductive outcomes such as implantation failure, recurrent miscarriage, and preterm birth. And then lastly, the endometrial microbiota composition before embryo transfer could be a useful biomarker to consider offering an opportunity to further improve diagnosis and treatment strategies, even more so when reported at the species level. So that brings me to the end of the talk. I hope we have time for questions if there's any.
Sure,
Did I talk too much?
Oh, perfect. Thank you very much, as always, for your presentation. So, is there any question?
Hi, yes. My question is, after treatment, once we use our EMA-analysis test and antibiotics are provided, should we retest again to confirm that the pathogens are no longer there?
Yeah. So that's a great question. We receive that question a lot. And this was a change we actually made in the US earlier this year, where we strongly recommend this test of cure. And there's several reasons for that. One could be, especially with complex profiles, it might be tricky to treat all the bacteria present at one time. So we want to make sure that the optimal microbiome has been restored. We also had a discussion with some physicians. Sometimes when we clear the microbiome of one pathogen, another one pops up because we think of the microbiome as a very competitive ecosystem. So again, ensuring that nice microbiome free of pathogens and bringing the lactobacillus to kind of protect the optimal optimization of the microbiome is extremely important. So we want to put the embryos back into a good home.
Is there an optimal time to do the biopsy, the endometrial biopsy, based on what time of the menstrual cycle? And the second question, the vaginal I'm presuming it's vaginal probiotics, and what is the frequency and duration for those?
Yeah. So the first question was, is there an optimal time to take the biopsy for the microbiome testing? And yes, so we always recommend during the secretory phase. And the reason for this is that we know the microbiome is going to be most stable under the influence of estrogen and progesterone. So we don't want to take, very close to menses, for example, where the presence of blood and the disruption of pH can lead to a temporary dysbiosis. Plus, during the secretory phase, specifically, is when the embryo will be encountering the endometrium. So we really want to understand the endometrium at that time. And then the second question regarding probiotics, This depends on which probiotic you use. So we have some options here in the US where it could be just as simple as I think like a 2-day long, some probiotics say 7 days. So it's completely up to which probiotic is chosen. We do recommend vaginal probiotics over oral probiotics because it's a more direct route to replenish the endometrium.
Okay. So thank you very much, Tiffany, and thank you all for being here today with us. Bye-bye.
Thank you.